Good morning, everyone. As Dr. Crampton said, it's a topic not only close to my professional interest, but also close to my heart, because I think one of the focuses of IBD is to give the patients really an ability to live a normal life, and for many young patients that means having a family and having a professional life like anybody else, and having children certainly for a lot of people is part of having a normal family life. So these two pictures probably summarise most of what I'm going to talk about today. It's the pills or treatments, and it's the concerns and the views of patients, really, and those two are quite integral to getting it right when it comes to having a family. So just to outline the talk, the most important question I want to answer today is, if I have IBD, can I have children? I'm going to talk a little bit about whether you can pass IBD on to your children. I'm going to talk a bit about fertility issues, because that's a particularly important topic, and then spend most of the time talking about, if you want to have a baby, how to plan for a pregnancy, looking at when it's best to have a baby, what do you do about medication before and after, and who do you actually speak to about that when you've got any questions about it, and a little bit about breastfeeding at the end. So who is really affected by inflammatory bowel disease? And as you know, it can affect patients at any age, but quite clearly, as you can see from those two slides, just showing you the rate of developing Crohn's disease depending on age, is that it happens in an awful lot of young people who are going to have it for the rest of their life. And it will affect many men and women before they have the chance to have children. So that's why it's such an important topic to talk about. So, most important question, can I have children? Well, the overwhelming answer is yes. But you've probably guessed it, there comes a big but. Why talk about it then? Well, first of all, not everyone actually knows that you can have children with IBD. There are enough non-specialist doctors out there who are not aware that actually it's usually not a problem. There's some patients who've not been actually given that information. There certainly might be some friends and relatives who think that that's a crazy idea rather than a good idea. So yes, most patients can have children without a problem, but for everyone it involves fairly careful planning of how to have children. So one great concern that I came across, not only in my research but in everyday patient encounters, is what's the chance of actually me passing on inflammatory bowel disease to my child? Well, as you all know, that there are people who have a family history where the disease runs in the family and it seems to affect nearly every generation. And it's true that there is a part of IBD that's inherited, and that's due to certain defects in genes, and that's probably a bit more true for Crohn's disease and ulcerative colitis. But in every case, that's only part of the story. Having all the genes that make you more likely to get it doesn't mean you will get IBD. Indeed, the vast majority with those genes won't get it. So there's a lot of environmental factors that come in, and I'm probably pointing to Dr. Crampton's talk later, who will go into that much more detail. Unfortunately, most of these we haven't really detected despite years and years of research. Certainly we know that smoking is detrimental. We do have some evidence that actually having dirt exposure protects you from getting IBD. We know that antibiotics in childhood might play a negative role, but the vast majority of these factors are poorly understood and not that well known yet. So the bottom line is, it's probably not that likely that you're going to pass on IBD. I'm going to ask a few questions throughout the talk, and they're all quite personal, so if you don't want to participate in the show of hands, that's entirely understandable, and don't feel pressured. But I'd like to know actually who in the audience had children after developing IBD. Oh, that's an encouraging number. Excellent. So the chance of actually passing on IBD to children is around 4 to 10%, and that really depends a little bit on whether it's run in your family already and whether you've got Crohn's disease or ulcerative colitis. But the bottom line is, it's less than 1 in 10 children that will actually get IBD if their parents are affected. It's a slightly different story if both parents are infected, because then you're both bringing factors from both sides in, and then it's a little bit higher. But overall, there's a very good chance your child will not get IBD. And it will depend on very many factors if it does get IBD. And as you do know, living with IBD may not be fun most of the time, but you can still have a decent quality of life with it. So from that point of view, I don't think many people should be put off having children by suffering from IBD. Talk a little bit about fertility, and that's one part of the talk where men actually come into the equation. A lot of the rest of the talk only applies to females. Most men do not have problems having children if they suffer from IBD. It's pretty much the same as in the general population. There's one drug that can temporarily make men less fertile. It's a relatively old-fashioned drug that we don't use that often anymore. It's called sulfasalazine. If that is a problem, once you stop the drug, within a few weeks it goes back to normal. So the bottom line is, for men, don't worry about it. Fertility in women is generally good. It might be slightly less than in women who are completely healthy, but generally speaking it's fairly good. But the best chance of falling pregnant is actually when you're well. When you have a disease flare, when you have grumbling disease over weeks and months, that just doesn't make the right environment for falling pregnant. Even a lot of women who have got quite active disease won't have regular periods and so on. So the best chance of falling pregnant is actually to get the disease controlled in the first place, and that makes it much more likely to fall pregnant. So as I said, the vast majority of patients should experience little problems. That is, in comparison to the general population, as unfortunately some part of the general population who are completely healthy will have problems falling pregnant as well. There are a couple of problems areas, and that can be in Crohn's disease, where the inflammation sits very deep in the pelvis near the reproductive organs that you need to fall pregnant, and those who've had surgery very deep in the pelvis. We also know that women who had a total colectomy for ulcerative colitis find it more difficult to fall pregnant. Again, that's the area where the operation was, and often the fallopian tubes where the ovaries are, they may be affected by scarring and so on. However, we've now got relatively new evidence this year that actually IVF works in these patients as it works in anyone else who's not suffering from IBD. So even if you've got problems falling pregnant, you should be able to access normal IVF services, and that might work for you. Has actually anyone in the audience experienced fertility problems? Just one. Well, that'd be reassuring. Good. The bigger issue is women not deciding to have children. And if you don't want children, generally that's perfectly fine. But we've got a feeling, and that comes closely out of new research over the last 2 years, that something is happening that we call voluntary infertility. That's not people not physically able to have children, but deciding not to have children. And it's much, much more common in inflammatory bowel disease. Indeed, it's 3 times the rate than in the general public. And that is of concern to us because we think that there might not be the message out there enough that you can actually have children. It might be some people making a lifestyle choice that they find the disease is enough to cope with without having to look after children and so on. There may be a variety of reasons, but certainly the rate at which we find women decide not to have children is alarming for us, and suggests that we need to get out there and get the message out there that if you want to have children, you can. So why do women decide to not have children? Well, as I said, some might not be aware they can. They might have relatively poor knowledge about the whole idea of pregnancy in IBD, or they might be particularly anxious about how the pregnancy would go and how the disease would go through the pregnancy. They might be worried about passing it on. And this is where we need to get out and get our message across. And there might have been some bad advice given to them. Certainly if you go onto Google and rather go into the NAC website or any of the hospital websites that give you good quality information, you might end up on an internet discussion board where everybody shares their bad experiences. Unfortunately, very few people share their good experiences on these discussion boards. You might have had friends, or unfortunately some doctors are not well informed either and might have given the wrong information there. So our job is to get the message out. The vast majority of women can have children, no problem. So when to have a baby? It comes back to what I said, what are the chances of falling pregnant actually? And as I said there is, the best chance of falling pregnant is when the patient has been really well for a while, what we call remission. Not only is that the best chance to fall pregnant then, you also got the best chance of actually having a good course of the IBD throughout the pregnancy. And in some patients that might mean that before falling pregnant, you might need to increase your medication. You might need to change your medication to get you well in order to fall pregnant. And it might mean in a small number of patients that we have to talk about surgery. And the question is surgery a good idea beforehand or not? If so, what kind of operation? Because depending on whether it involves deep in the pelvis surgery or not, it might actually reduce the chance of falling pregnant. And crucially, is it a good idea to have surgery before having a baby, or would you delay it and try to treat it medically? So there's a lot sometimes to think about in people who are not that well yet but want to have a family. Medication and pregnancy is very, very worthwhile talking about, in my opinion, and from all the patients I've interacted with, that's their greatest area of concern. The most important message here is that active disease, i.e. you've got symptoms that are going on all the time, is not good news. It reduces your chance of actually falling pregnant, and if you've got active disease during pregnancy, it's not good for the baby either. There is definite evidence that it leads to early births, but the complications that might be associated with that. The babies tend to be smaller, and unfortunately in some cases where the disease is very active, it can actually lead to a loss of pregnancy and a spontaneous abortion, and that would certainly be what we want to avoid at all cost. Hence, from our point of view, it is really important to keep your disease under control before, during, and obviously also after the pregnancy. In my mind, and in most of patients' mind, there's no question who you want to be. Do you want to be the happy woman on the left who's eating fruit and has a healthy diet, or do you want to be the pillhead on the right who has to take lots of medication to get there? But unfortunately, it's not as an easy choice that you can just say I go with the left. Can I just ask those who've had a baby, who of them stopped the medication while they were pregnant? Okay, and who continued? 50-50 split here. Thank you. The most important message when it comes to medication, for the vast majority of medication, is that the benefits probably outweigh the risks. As I said, being well is really important, not only for the mother but also for the baby. And most of those medications have a very small and negligible risk to the baby. That is, except methotrexate. We don't use it that often anymore in inflammatory bowel disease, but when we use it, this is a very, very poisonous drug when it comes to babies. Also when it's given to men, so when you're on that medication and your partner wants to fall pregnant, you have to stop that beforehand. You have to stop it. Good 6 months, that applies to men and women. That's the only drug really, when you take that falling pregnant is really not a good idea. But for most patients there are alternatives. So if anyone is on that medication and wants to have babies, go and see your specialist and they can change things around probably for you. I'm going to talk about the three main drug classes very briefly. Most patients will probably have had experience with any of the mesalazines, from Azacol to Sulfalk, all those names. They're roughly all the same ingredients. All those are extremely safe. And we would certainly encourage patients to take those. Those are the safest drug we've got outside pregnancy and in pregnancy, and they do work very well. The next drug class, with azathioprine and 6-mercaptopurine, they're generally safe. They're a bit more problematic when it comes to getting the doses right and so on, and patients on those know that they have to go for monitoring a bit more. They're generally safe. There are a few warnings with them, but they work well, and they're certainly much better than the only alternative in this scenario, which is being on steroids. Biologics are the drug class for the most severely affected patients, and generally the advice is they're safe and you need to be on them. We only use them in severe disease, but those patients are at the highest risk actually of getting a flare that might put their pregnancy into a dangerous territory. So in those cases the benefit is very high and the risk is rather well controllable. We tend to stop them in the last trimester, so the last 10 weeks before delivering, and that reduces the chance that the baby has got any of that medication going around. But all those three drug classes are, generally speaking, acceptable to be used in pregnancy, and whether they're needed in individual cases, it's best discussed with your specialist. What a lot of women have asked me is, can I stop my medication before falling pregnant? And it really depends on how your disease has been over the last few years before you want to fall pregnant. For the vast majority of patients, the bottom line is you're probably better on the medication than off it. But if you've been really well for a long time, your medication has not needed any changes, you've not had a flare or so on, then it might be worthwhile coming off it. But then definitely see your specialist about it, And if you come off it, I would certainly, and I think most colleagues would do the same, would want you to be well for at least 12 months before actually trying to fall pregnant, to prove the point that you can actually be well without the medication. Who to talk to about your medication, and that really is, it's a very specialist area. And hence, really, I would say, like, talk to your IBD nurse and your gastroenterologist. General practitioners, midwives and obstetricians often have very little knowledge of these IBD drugs in the setting they're used in. And that's because it is a specialist area. It's not what they deal with every day. All usual sources of information will give you, unfortunately, the wrong answers. So the BNF, this is a drug bible every doctor, nurse and pharmacist uses, will not be helpful at all. On the internet you might hear horror stories. If you go to the NAC website, you get actually very, very good information. And your pharmacist, unless they've got an interest in the area, will probably be a little bit shocked and advise you to stop as well. So my personal advice would be, don't bother with those sources. Speak with your IBD nurse, with your gastroenterologist, and you will get much better answers. The problem is generally that drug companies need a license for a drug to be used in pregnancy. All these drugs do not carry a license, and it's a simple commercial reason for them. It's a very, very small market. They can't make much money for it. It's very expensive to get a license. They don't apply for it because it makes no financial sense for them. Hence, all these drugs will come with official warnings. But in your case, if your individual case warrants being on the medication, certainly the benefits outweigh the risks. I'm going to give you a little bit of a nightmare scenario, and just to highlight what can happen. Let's take a 26-year-old woman, ulcerative colitis for 5 years, is on a mesalazine. I've just used Azocol for fancy, it doesn't really matter which one she's on, and she's well. Falls pregnant unexpectedly, is happy to have the baby, but goes to her general practitioner worried about what to do about medication. And the general practitioner will do what most of his colleagues or her colleagues will do. They will advise to stop the medication. They'll look into the BNF. The BNF says, oh, not sure whether it's safe or not, and they will stop the medication. Then the patient comes to clinic for a routine appointment 10 weeks later, and unfortunately she's having a flare. She's having diarrhea 15 times a day, she's having bleeding, a little bit dehydrated, very tired because she's anemic. And now you're in a situation where you not only need to restart the Azocol, but you may have to actually start some steroids for at least 8 weeks. The flare is actually putting the pregnancy at risk. And actually you end up with much more medication and much stronger medication than you would have been on if you had stuck to the medication. So we're trying to avoid these scenarios, and the best way we can probably do it is we plan ahead. So our advice would generally be, ideally plan your pregnancy with your IBD nurse and your gastroenterologist. When you get questions over your medication or your symptoms, then get in touch with us. And we would generally advise, don't stop or change your medication without speaking to us. We can probably give you much better quality advice that you can get at any other source in this special scenario. What happens actually with your pregnancy when you have IBD? Well, the chance of having a flare during pregnancy is pretty much the same as before and after. So it does happen to some women. We can treat it usually, and usually we get good outcomes with that. Some women actually get better when they're pregnant, and when they experience that, that can lead to them. Actually, I've had one patient who've had many, many babies, and one of the reasons she liked having babies is that she always got really well during her pregnancy. I'm not sure how she copes with looking after that many children, but there's a few women who will get significantly worse during pregnancy. That is extremely rare, so that should not put anyone off, really. As I said before, babies tend to be a little bit on the smaller side, and they can, even when things have gone well, and they can be born a couple of weeks premature, but usually that is really only a couple of weeks and leading to not much problems. Giving birth. Well, first of all, I am a gastroenterologist by training. I'm not an obstetrician, so I can only give you the gastroenterologist perspective. If there's a need for the baby to be delivered by caesarean section because it's in the wrong position or so on, that applies to women who've got Crohn's disease or ulcerative colitis, or who don't have anything at all, really. From that point of view, there's still a chance you might end up with a caesarean section. But generally speaking, a normal vaginal delivery is perfectly possible for the vast, vast majority of patients. If you need to have an episiotomy, that's a little cut in case the baby doesn't come out without help. That is perfectly safe. There's only very few scenarios where we are advising to go for a cesarean section rather than a vaginal birth. And that one is women with active perianal Crohn's disease. When you've got ongoing fistulas, there's an abscess ongoing, or there are cetons in place and so on, that usually means a vaginal delivery can lead to very nasty complications. Things may not heal that well. So that would be one scenario. If you had Crohn's disease in the perianal area in the past, it's all healed up and not been a problem for a while, then you can probably have a vaginal delivery, but it's worthwhile speaking about that well in advance before giving birth. And the other area is women who've had a pouch after having a colectomy for ulcerative colitis. In those cases, most surgeons would want the women to have a cesarean section rather than a vaginal delivery, because they're worried about that tears or incontinence might arise from it. There are a few women, and it's published, that they have done well after giving vaginal delivery, birth through a vaginal delivery, but the vast majority of doctors would their advice for to have a cesarean section. So generally speaking, the vast majority of people can have a vaginal delivery, but it's worthwhile planning this ahead and that it's documented in your obstetric notes, so when it comes to giving birth, there is not a big debate suddenly what's happening. Last topic is whether we talk about breastfeeding or whether patients prefer bottle feeding. And obviously there is no right or wrong advice. It's a woman's choice what they want to do, but we can at least outline a bit the evidence behind it. Breastfeeding is often advised because this is the best possible nutrition for the baby. It has several advantages over bottle feeding. Actually, breastfeeding may protect children from developing inflammatory bowel disease. That data stems mainly from healthy mothers rather than mothers with inflammatory bowel disease, but the same effect may probably be true. So from that point of view, it's not definite, but there's good enough data to suggest that it might help protecting against it. All drugs are generally considered safe, again with the exception of methotrexate during breastfeeding, but you have a little bit more of a choice. When you're pregnant, you need to stay well. There is virtually no choice. If you have to take a medication to stay well, you have to put up with that. But once you've given birth, you can actually make an active choice to not expose the baby to any medication that might be in very tiny concentrations in the breast milk by bottle feeding. And because there's a bit of a more choice, then you might actually look at the risk and benefit a bit differently. In the end, it's personal choice for every woman, but it's worthwhile discussing again that with specialists who've got a bit of experience in the area. So this is our aim. We like to see lots of healthy babies. We're really happy when it happens. Actually, it makes us feel rather good because we know we've achieved something more than just disease control, actually trying to help patients have a normal life. So it makes us happy and hopefully makes all the mothers with IBD happy. Ideas for the future. Again, this is now much more my personal take than agreed evidence, really. I personally think we need to look at what is done in other disease areas like diabetes. And I think we should have combined clinics with specialist obstetricians so that women who want to have children can actually get all the advice beforehand, during pregnancy, and thereafter in one setting from named specialist rather than rather fragmented care like we often have it today. I think we should have personalised information for all women soon after diagnosis. I know once you get diagnosed you get an awful lot of information and it's not the right time to get it in the first couple of appointments. But at some stage during the first year we should probably actually make an effort to talk about this, because if you're 19, maybe you're going to university, there's lots of other things going on, it might not be on your mind, but if it only comes onto your mind 15 years later or so, then we've probably not done our duty properly either. So we should have joint out care throughout trying to fall pregnant throughout the pregnancy and during breastfeeding, and that's my vision how we should have services maybe in the next 5 to 10 years. Thank you.